let's just give you a cycle off and just have you celebrate. My view is that unless the patient, and I think this is what also Joyce mentioned, unless the patient has a contraindication to T-DXd and pertuzumab, I think most people are going to start with that. I think the question is, until when do you continue it? And that would be my strategy, is if this combination is approved, my strategy would be start with the dual, with the T-DXd pertuzumab, unless you have a reason not to, bad lung disease, concern about toxicity of some sort, and then continue that. Now, continue that until bothersome toxicity, beyond maximum response, until maximum response plus 2 cycles, in perpetuity as long as the patient is doing well, versus a switch to an all biologic regimen. I think that is where we have to allow doctors to be doctors and for the patient-physician relationship to rule supreme. One last point related to this, I share the views of Dr. Shaughnessy on patient perspective.
Certainly.
I shared stories about patients who I convinced, I actually started patient on pure anti-HER2 therapy without even induction. And did well for 2.5 years and progressed. And we talked about it and I said, let's do T-DXd. She had to be convinced to take T-DXd. And every cycle she would say, I don't want it. I'm bleeding, I'm worried, I'm all that. Before we got to San Antonio, I started to say, you've been doing so well on it for so long. How about we give you Christmas off? Let's just give you a cycle off and just have you celebrate. You know what she said? No.
She's doing what?
No. I am going to continue. She said, you may have to stop it later, but right now,
yeah, that's fantastic. That's amazing. And that speaks to how patients are doing. Yeah, that's true. Dr. O'Shaughnessy, there's something very interesting when you look at the PFS curves. The separation seems to happen at 5 to 6 months compared to THP, right when it's time to drop the chemotherapy on the Cleopatra arm. Does that speak to the fact that we need to continue T-DXd and not stop and go to a maintenance to get that fantastic benefit that we see the 14 months plus, or you don't think that has a role?
I think that they're very different regimens. T-DXd is so powerfully pro-apoptotic, and that dual inhibition that you get with T-DXd and pertuzumab, you're getting rid of that HER family, and you're just, it's extremely good anti-tumor activity. So it may be that curve speaks more to the fact that on the Cleopatra regimen, that stopping the taxane isn't the best thing to do. Probably because you get 30% PIK3CA and other mutations in that pathway too. It's not just PIK3CA. I don't know that we really know for sure how long to keep going with it. At some point, it's just going to have maximum cytoreduction. You're going to have the maximum cell kill. And then it's really a question of maintenance, essentially. And it may be different for different patients depending on how much tumor there is, too. And a lot of these patients are de novo metastatic, so we can go by their breast exam and we're going by their PETs. And so we kind of know when we've got maximum cytoreduction. And then the question is, what's the best way to bar the doors in terms of resistance emergence? And this really, when you want to get your metastatic disease down to the smallest possible amount in order to prevent or forestall emergence, essentially, And so that would speak to just maximizing it. I think it's going to be different for every patient. It's going to be on how much cancer there is.